Hello everyone. I'm delighted and honored to have Dr. Phil Lieberman here to talk about the landmark study, Anaphylaxis in America, regarding what doctors know about this potentially life-threatening condition known as anaphylaxis. This webinar is offered by Kids with Food Allergies as part of its Education Outreach Program. I'm Linda Mitchell, Senior Vice President at the Asthma and Allergy Foundation of America, or AFA. Kids with Food Allergies is a division of AFA. I have the privilege of being your moderator this evening. Guest presenters for all of our webinars are doing so as volunteers without compensation. They also prepare their presentations based on the clinical evidence. On behalf of AFA and KFA, I'm very grateful for Dr. Lieberman to donate his time to be here with us tonight to discuss anaphylaxis. Many of us here tonight are raising children at risk for anaphylaxis or with a history of anaphylaxis or both. I thank you for joining us here this evening to find out more about anaphylaxis and the physician's survey that assessed their level of understanding about anaphylaxis and quality of life. I have a few housekeeping details to run through before we get started. First of all, tonight's webinar is made possible through a sponsorship from Sanofi US. The Anaphylaxis in America study is an independent research project of AFA that was sponsored by Sanofi US. We rely on donors and corporate partners like Sanofi for the financial support that enables us to develop educational programs for families. Next, please remember that this webinar is of a general nature only and is not medical advice or legal advice. You need to consult your own physician for any medical advice you seek with regard to food allergies and any other medical conditions. Today's webinar is being recorded, and you will get a link after this recording in a few days. You will get an email in a few days with a link to this recording if you would like to see it again. Later in tonight's webinar, we will stop to give away some wonderful gifts from our corporate supporters, Sun Butter and Hope Page Designs, valued at $20 each. The recipients of these gifts will be picked randomly from those still in attendance later this evening. And when we end the webinar, you will see a survey. Please share your impressions with us as we take your feedback seriously to help improve the future direction of our webinar series. And now I'd like to introduce our speaker, Dr. Philip Lieberman, so we can get started. Dr. Phil Lieberman is currently Clinical Professor of Medicine and Pediatrics in the Department of Internal Medicine and Pediatric, Division of Allergy and Immunology at the University of Tennessee College of Medicine. He's a graduate of the University of Tennessee College of Medicine and also completed his internal medicine training at this institution. He did his Allergy Immunology Fellowship at Northwestern University. Dr. Lieberman is the former president of the American Academy of Allergy, Asthma, and Immunology and the American Association of Certified Allergists. He has also served on the board of directors of the American Board of Allergy and Immunology. He is presently in charge of the Allergy and Asthma Disease Management Center of the American Academy of Allergy, Asthma, and Immunology. He is the author of more than 225 scientific publications and is the co-editor of the text Allergic Diseases. His present investigative interests are in the fields of asthma and anaphylaxis. So thank you for joining us here tonight, Dr. Lieberman. I'm very thrilled to have you here, so let's get started.
Thank you very much, Ms. Mitchell, and it's really a pleasure to be here. I want to preface my discussion with one thing that I think you ought to know. I am an allergist, and I have been writing about anaphylaxis since the 70s, so it's my major area of interest, but it really doesn't qualify me to give this talk as much as my other role, and my other role is father. And I am the father of, I call him a young man, he's no longer young, who has had at least 20 episodes of anaphylaxis. So I have had those heart-stopping moments when we're in different towns and I get a call and I await the emergency room to try and give them instructions as to how to handle the case. And he has fostered 2 other children, my grandchildren, who also suffer from anaphylaxis. So I share with you not only the sympathy involved with a parent who has children with this disorder, but also empathy, because I've experienced, I promise, everything that you have experienced with this condition. What we're going to talk about today is a survey called Anaphylaxis in America. And this survey is, can you see my screen now? By the way, we may have a technical glitch and I can't tell. Are you able? Today's discussion will be a brief background public and patient survey, the doctor survey about anaphylaxis, what they know, and where they can improve, and then we're going to have a question and answer session.
Dr. Lieberman, can you put it in presentation mode? We're seeing it in construction mode.
Yes, I can, if you've got my screen.
We can see your screen, yeah.
Great.
But we're seeing it as if you haven't started the presentation, the slideshow yet.
Okay, I've got it in slideshow mode as of this moment. It's not working? If not, maybe I'll turn, let's try it one more time. So on my screen is slideshow mode. And I've got show my screen.
Yes, it's up now. Thank you.
Okay, great. So I have control of the slides, correct?
Yes.
Good, okay. Well, I want to talk about this survey. It's called Anaphylaxis in America, and it's an independent research project of AFA that was sponsored by Sanofi. And I want to give great credit to the first author on this, Dr. Robert Wood, who actually spearheaded the study. Dr. Wood is at Johns Hopkins and is an internationally known pediatric allergist. The other names on this are also well-known experts in the area, and I'm very honored to include myself with this group. And to go back, the brief background is this survey had 3 parts: a public and a patient survey, and then a doctor survey. And what we're going to talk about today is the doctor survey. And we showed this slide previously, so you know the objectives. This study, the public study, was designed to assess public awareness, attitudes, and the prevalence of anaphylaxis. 1,000 adults were surveyed. And you're going to see some quite surprising results from this very briefly as we go through the talk. The patient survey was to assess patient and parent awareness, attitudes, and behaviors of 1,059 adults and children. And the physician survey was to assess the experience, the attitudes, and the knowledge of physicians regarding anaphylaxis. And we studied 5 different physician groups, not only allergists but, with internal medicine training, but allergists with pediatric training, emergency department physicians, pediatricians, and family doctors. And the background from the patient and public surveys was really, to me, astounding because we found that anaphylaxis, as you can see here, occurs at bullet number 1 in 1.6%, or about 1 in 50 Americans. And that figure includes people who said, A, that they felt their life was in danger, B, expressed at least 2 classic symptoms of an anaphylaxis event, and C, required an emergency room visit. So these people had significant episodes. If we looked at people who probably had anaphylaxis, they didn't have to experience all 3 of those criterion. 5.1% of Americans had what could be called as a probable anaphylactic event. This is incredibly high and much higher than all other data we've ever seen. And knowing that, it's also important to know that we clearly understand that most events are not reported, so that many go unreported. In my practice, usually the patient before seeing me has had 1 or 2 other events and many times they've never told a physician about those events. So clearly we know that more effort is needed to educate the public and patients about anaphylaxis. This article about this physician survey was published in one of the leading international journals, the Journal of Allergy and Clinical Immunology, and it's very recent, in January of 2015. And what we're going to do is go over how we did this. Again, there were 318 physicians surveyed from 5 groups, as I mentioned: allergists with pediatric training, allergists with internal medicine training, emergency doctors, emergency room doctors, private care physicians, and pediatricians. And we wanted to learn about their experience with the disease, about their knowledge of the disease, about their behaviors in treating the disease, and what their awareness of the aspects of anaphylaxis were. With that introduction, let's actually look at the data. This slide is about experience. What is experience of these groups of physicians in dealing with a patient who is having an anaphylactic reaction at the time that the physician was seen? So we see here something that's very encouraging. The vast majority of these physicians have actually seen and dealt with a patient who was experiencing an anaphylactic reaction at the time of the event. Noteworthy is that family doctors have seen statistically less numbers compared to emergency department physicians and allergists, but still 82% of family physicians, which is the green bar fourth from your left, have seen an episode of anaphylaxis and had an attempt to treat it. Looking at this slide is what we learned about their knowledge of the symptoms of anaphylactic reactions. And there are a few points on this slide that were surprising. And what you're looking at here is allergists in the yellow bar. These are allergists with pediatric training. In the blue bar, we have allergists with internal medicine training. In the red bar, emergency department physicians. And in the sort of a burnt orange, family practice and general practitioners. And in the green, pediatricians. Probably the most important surprise that we get from this is the last manifestation down, skin reactions. We know that skin reactions are probably the most frequent manifestation of an anaphylactic event. Flushing, itching, hives, and swelling of the soft tissue called angioedema, where the lip or the eye or other sites may swell. And if you look at that, it's quite surprising that the physicians, even allergists in a very significant proportion, answered that they weren't aware of that. I have a feeling that that might be due to the way the question was asked, because we didn't use medical terms. I think had we used, for example, urticaria, which stands for hives, we might have got a different response. But it's good to know that 80% recognize that breathing problems, which account for about 50% of the fatalities in anaphylactic events, was well recognized. Dizziness and fainting was well recognized. There are other symptoms which are rarer, and the next slide takes a look at other symptoms. For example, in an infant or a young child, on the top bar, sudden behavioral changes can occur. Certainly anxiety can be part of the problem. It was not recognized very often that loss of bladder control, along actually with seizure activity, if the patient loses consciousness. Throat itching is actually very common, especially in food-induced events, but quite surprisingly, it wasn't recognized by a large number of physicians. Hoarse voice was not recognized, but more doctors recognized the presence of cramps and abdominal pain. But it's a little surprising that these other manifestations were not recognized by more doctors. On the next slide, we wanted to assess the behavior of physicians when they are actually treating an anaphylactic event. The question was, what do you do when a patient is having an anaphylactic reaction? And if we look at the bottom, we look at the physicians who said, I would administer epinephrine. And that is very encouraging because you can see that the vast majority, the lowest in family practitioners was about 80 or so percent, and the highest in allergists with internal medicine training, very close to 100%. Now, however, there is a paradox here, because when you actually look at data to see what has been done, it does not reach this percent. So what doctors say that they do sometimes belies their actual recorded behavior when statistics are taken from actual treatments that are given. There may be several explanations for this that probably don't warrant going into at this time, but with one exception, and that is there are certain cases, although we would treat with anaphylaxis, that aren't because not enough of the symptoms are recognized, or perhaps the physician who's taking care of the patient may be worried about side effects of the drug, epinephrine, and we'll talk about that later. The next slide continues to look at behavior of physicians, but in this instance, the question was, what do you give patients who report that they have experienced an anaphylactic reaction? So in this case, the physician is looking at a patient who has had a diagnosis of an anaphylactic event in the past. And actually, ideally, theoretically, one would want the vast majority, if not all, to give an epinephrine auto-injector to these patients. And if you look at the results, they're a little bit shy of what we would like. And quite surprisingly, emergency room doctors were the least likely of that group who would report giving an epinephrine auto-injector to these patients. And in fact, that is consistent with reported statistics of what is actually done in the emergency department. One of the reasons that physicians may not give an auto-injector, although we would like 100% theoretically, is that some patients who have experienced an anaphylactic event may have experienced it to an agent which is almost universally avoidable to that patient in the future. For example, a drug perhaps that's not on the market any longer, or a drug that they can readily avoid that has very little cross-reactivity with other drugs. And in that instance, the physician may not give an auto-injector. But surprisingly, when we look at the top of that slide, some would actually do nothing, a very few. And the other thing that's really missing from this is that although our guidelines state that the vast majority of individuals who experience anaphylaxis, especially to the two major causes, food and drugs, and even more so to an insect sting, one of the top causes, should definitely be referred for an allergy evaluation. And yet, as you can see, the majority of physicians, when asked this question, do not. And many do not discuss preventive measures, clearly an indication for any patient, a must for any patient who's experienced an event. Some would prescribe steroids, and we don't think that's really very helpful for the acute event. They take too long to act. And the same thing is true with antihistamines, although we see here that many would prescribe antihistamines. And in fact, we know from prescription data that antihistamines are prescribed, unfortunately, to patients who have experienced that event more frequently than an automatic epinephrine injector in many series. Going to the next slide, we asked physicians about their awareness for the contraindications for epinephrine. And so the question was, is there any absolute, that means 100% contraindication you would not give it to prescribing self-injectable epinephrine to a patient who had experienced an anaphylactic event? And this is a little bit shocking to me, because you see significant percent of physicians, family doctors and emergency department physicians are the highest, and even, I'm surprised to say, allergists as well as pediatricians do feel that there are absolute contraindications to prescribing self-injectable epinephrine to a patient experiencing an event. And clearly, in a life-threatening event such as this, our consensus opinion, according to every guideline that we have, there are now 6, say that there's no absolute contraindication. So that even a patient, say an elderly patient who has heart trouble, if you're faced, we feel, with the decision to give epinephrine for a life-threatening anaphylactic event, even in the face of heart trouble, it's better to err on the side of commission than on the side of omission. On this slide, we asked about various anaphylactic questions, and the questions were posed as to give a yes or no answer. So the first question was, do you agree with the statement, restaurants are required to have epinephrine autoinjectors available? And look at the number who said that, although obviously they are not. So it expresses a naivete about this particular question in a significant number of physicians. The next are schools are required to have epinephrine autoinjectors available, and of course they are not. And yet even more physicians, actually the majority, felt that they were. Are ambulances required? And that a higher percentage asked yes. And the next question is really interesting. When we look at anaphylactic deaths, they occur at 2 stages in life. 1, during the teenage years, and 2, in the very elderly with comorbid conditions such as arteriosclerotic heart disease, they've had myocardial heart attacks, or they have bad asthma, etc. In those 2 age groups, readily explainable is the elderly, but not readily explainable is a very healthy teenager. But the reasons that they are at risk, and clearly they are, is they have intimations of immortality. They have no perception that they are at risk, number 1, and number 2, they often find it socially unacceptable to give themselves an injection among their peers, and they have a very low carry rate of their autoinjectors. So it's a patient population that physicians should be aware of, because they have to emphasize in their educational efforts the need for all of these things in the teenager. The next question was, asthma is an important risk factor, and it's encouraging that the vast majority, rather, of physicians realize that, and it is clearly a risk factor for mortality. On the next question, this one was disturbing to me. This assessed the quality of life, how physicians felt that the quality of life of their patients with anaphylaxis, how their quality of life was affected. So the question was, for the average patient with severe allergies, how much would you say the condition impacts their daily life? And we know that allergies have a very profound impact on the quality of life, especially in patients who have had anaphylactic events. And yet, when one looks at physicians responding to this, if you look at the bottom of that, the red are physicians who feel a lot. And you see that pediatric allergists do feel that that's true. If you look at family doctors, they don't. And I once wrote a chapter on that, and we say that allergic disease is the Rodney Dangerfield of diseases. It oftentimes does not get respect, even though that we know from surveys quality of life is clearly affected. And being the father and grandfather of children with severe allergies, I can tell you that for sure. So, in summary, on the physicians surveyed, most had treated anaphylaxis, 81 to 96%, with epinephrine. 63 to 79% reported prescribing injectable epinephrine for patients who had a history of anaphylaxis shy of what we would like. Only 5 to 19% referred to a specialist, and that's clearly shy. 21 to 38% think that there are absolute contraindications to epinephrine. 81 to 94% believe epinephrine is required on all ambulances. 49 to 56% believe it is required in all schools. And 18 to 33% believe epinephrine is required in all restaurants. And only 10%, very disturbing, of family practitioners and 31% of pediatricians believe that severe allergies have a major impact on the quality of life. And the conclusions, therefore, are this nationwide survey reveals likely deficiencies in physician knowledge of anaphylaxis. Knowledge gaps are essentially apparent, or especially apparent for primary care and emergency doctors who are most often the physicians on the front line who have to treat patients with anaphylaxis, especially emergency room doctors. And this survey demonstrates the need for increased education to optimize patient care. And I thank you for listening, and now we're open for some questions and answers. Thank you very much.
Thank you, Dr. Lieberman, so much. Really appreciate your time with this. And I didn't know that you were a dad and a grandfather of children with food allergies, so now I think I love you.
I love you too, Melanie. Don't tell my wife.
I think your wife is on the phone here. So
she's sitting right here.
Mrs. Lieberman, I say that with the greatest respect for your husband. I do have a question that came from the audience before you get started, and that is, can you explain what the word contraindication means and what you were referring to when you were talking about the contraindication of epinephrine, because that does confuse people?
Thank you very much. Physician speak is so innate within my being that I sometimes lose the sense that the crowd that I'm talking to may not understand, so pardon me. But a contraindication means that there's a very strong reason not to give a drug. And for example, if you are allergic to that drug, that is a contraindication. And they're graded. An absolute contraindication is that you should never, under any circumstance, ever give that drug to the patient. A relative contraindication is that you can give that drug to the patient under certain conditions based upon the judgment, the individual judgment of the physician. I hope that clarified that. And 21 to 38%, as this slide showed, thought incorrectly that there was an absolute contraindication to epinephrine, which means that they felt under no circumstances could they give epinephrine to the patient in question, and that is not true in the face of an anaphylactic event. In the face of an anaphylactic event, there is not an absolute contraindication.
Thank you very much for clarifying that. And somebody asked about what version of the Journal of Allergy and Clinical Immunology these were in, and we will include that in the follow-up email we send to you, so don't worry about that.
Okay, thank you.
Mm-hmm.
It's a January version of 2015, I believe, though.
That's correct, yes. Yeah. Okay, so let's go to the first question. How much training do pediatricians, family doctors, and emergency room doctors have in identifying allergic reactions and treating them?
Thank you. It's highly variable. Some family doctors, pediatricians, as well as internists receive absolutely none, other than perhaps one lecture during their whole training years. Those are doctors who train at universities which do not have an allergy immunology division within the university. And I'm sad to say that that's a significant number of institutions, and we are doing our very best to try and change that. There is a fund at both the American College and American Academy of Allergy, which funds institutions to establish programs, and we're trying to make headway in that regard. Even those who do have an institution, such as my university at the University of Tennessee, have allergy training as an elective rather than a requirement. So only those doctors who decide to take an elective in allergy immunology will rotate through the allergy immunology program. So there are many physicians who go through training in pediatrics, family physicians, and internists who have very little training. Emergency department physicians are, I'm not as familiar with their training, but they are trained to deal with all emergencies, so they clearly achieve a greater degree of training than many of the other specialties. I think we can take the next one.
How can some ER doctors prescribe oral steroids after anaphylaxis and some don't? I've heard it can prevent biphasic reaction. Can you explain what a biphasic reaction is, and is that a myth?
Well, that's an interesting question, as are all of the questions if we want to proceed. But let's first talk about the biphasic, and let me tell you what it is, and then we'll answer the question about the use of oral steroids. A biphasic reaction is a reaction, an anaphylactic reaction, which resolves either by itself or with treatment, usually within an hour of the time of the onset of the event. And then, without further exposure to the cause, that is the allergen, a recurrence occurs. And the symptoms are usually identical. They may be the same or less or more severe. It's unpredictable than the initial reaction. And it usually occurs within about 4 to 6 hours, sometimes as often as 2 hours, after resolution of the first event. It's one of the most important reasons that we require or ask a patient to go to an emergency department even after they've treated themselves. Because even though that episode may resolve, on an average, as many as about 16 to 20% of episodes will exhibit a biphasic response. And so the symptoms can return even when the patient has felt reassured that they're well. Now, the question then was, why do some emergency department doctors prescribe oral steroids, and is it because they can prevent a biphasic reaction? The answer to that is, in essence, we don't have an answer. And we do not have significant data to indicate that steroids, including prednisone or other steroids, have any effect on the biphasic reaction in anaphylaxis. There are studies which say that it does, and there are studies which say that it doesn't. In my experience, They do not hurt, and since there's no harm in giving, I would not feel uncomfortable at all in using them, and I would not criticize anyone for their application. But let me pause. That steroids are not treatment for the first phase, for the acute event, and that must be very clear. They take an hour or longer to take effect, and an anaphylactic event can be fatal far earlier than within an hour. So to think that they have any effect on the first response, on the acute event, is incorrect. And so we don't advise the use for that rationale. For that rationale, the acute event, there is actually only one effective drug to prevent fatalities, and that is epinephrine. And we'll probably get to that a little bit later as well. So can we have the next one?
If I'm feeling better after I get epinephrine, why do I need to go to the emergency department? Is it because of the side effects of epinephrine?
That's quite interesting. I have had patients in my own practice after they have had an event, and they've given themselves Benadryl, a diphenhydramine, generically I should use, or an antihistamine of that sort, and didn't go to the emergency room, and they come in, and I re-instruct them that epinephrine is the only drug. It's the one that we want them to take. And they respond to me. They said, well, I didn't take it because you told me to go to the emergency room, emergency department, and I didn't want to go to the emergency department, and I was afraid you told me that because the epinephrine was going to cause some bad event. And it's not true that we tell them that because of any side effect of epinephrine. We've already mentioned that there's no absolute contraindication and that it's the only drug that will prevent a fatality. You are asked to go because 30%, anywhere from 20 to 30%, either because of a biphasic response or because of a failure to respond to the first injection, will require 2, and I add emphatically, or more injections. A significant percent of people, according to data that we have, require 3 injections, and a few even more. So we want you to be in a facility so that if that happens to the patient, they are under observation and can be further treated. I think we can go on.
Okay. If my symptoms are mild and I have to have them go away in the past, can't I just take Benadryl rather than give myself a shot of epinephrine? And in a related question, will antihistamines mask the signs of a more severe reaction?
We're going to deal with the related question first, because I can answer that one quite quickly. The question was, will antihistamines mask the signs of a more serious reaction? The answer to that is no. Antihistamines can be helpful after an hour, maybe sometimes more, but not sufficiently to mark a significant to prevent a significant reaction. They simply don't have the power to do that. It's not that they shouldn't be given as an adjunct therapy, that is, a therapy added to epinephrine. Perfectly fine, just like corticosteroids can be given after epinephrine. But neither antihistamines nor corticosteroids act fast enough, and they may have a later effect, perhaps, that might be helpful, but they cannot replace epinephrine as the drug of choice. Now, if my symptoms are mild and they've had them going away in the past, can I just take Benadryl? And that's a very tempting treatment, isn't it? It's so much easier. You don't have to give yourself a shot. And the answer, though, is no. and let me tell you why. These are the reasons. Number one, a previous mild reaction does not portend a future mild reaction. It is totally non-predictive. We have, in the largest series of deaths due to anaphylaxis, quite a significant number of patients who had had a mild reaction which resolved with an oral antihistamine, who on the second reaction died. And so the fact that you've had a mild reaction is non-predictive. We have very good, solid data to indicate that. Number two, one cannot predict the severity or the rapidity of the progression of an event based upon an initial mild set of symptoms. We know for a fact that there are many deaths of patients whose symptoms began very slowly and appeared very mild, who within a matter of minutes progressed rapidly to either a respiratory or cardiovascular death. So the fact that it's mild at the onset does not predict how bad it'll be within the next 10 to 15 minutes. And the fact that you've had a previous mild reaction does not predict that the next reaction will also be mild. So I don't want to frighten anybody, but just let me cite you some solid figures to impress this fact on you. The time in our largest series of death to a cardiovascular or respiratory death, the median time, that is sort of the mid-time, for food was 30 minutes. The median time for an insect sting was 15 minutes. And the median time for some injections given by a doctor in his office or her office was 5 minutes. Now, considering the onset of activity of these antihistamines is like 50 minutes or so by injection and longer by pill, and for steroids is an hour or more, you can see that although they may be helpful later on, they do not act fast enough to prevent mortalities. Okay, I think we can go on.
Our allergist plan says to give epinephrine when the allergen has been eaten or 2 or more body systems are involved. This means we are giving it before any hives and wheezing, and then I'm arguing with the EMTs and the emergency doctors because they think my child didn't need it when he was only vomiting and starting to turn red and coughing. How do we deal with this?
Well, maybe one way to explain this to you is to cite the longest 10 minutes of my life. Every parent has these heart-stopping valiant efforts in conjunction with emergency department physicians. One is called SAFE, that is Safe and Effective Treatment for Anaphylaxis, and there are others who have tried to overcome this failure to recognize an allergic event as potentially fatal. So you are, unfortunately, going to face this situation until we're able to conquer this, if ever. And you have to be persistent, as I was, and fight these misunderstandings. Stand up for yourself, because you are correct that this is threatening. Now, that deals with arguing with the EMTs or the emergency doctors, and you're unfortunately going to encounter that. And the other is our allergist plan says to give epinephrine when the allergen has been eaten or 2 or more body systems are involved. This is one of those areas where clearly we know epinephrine is the drug of choice, but there is some difficulty in interpreting when it is to be given, and there's some contentious arguments in this regard. I'm going to give you my take on this, and I think that that is the take of the consensus of experts, and it is the take in our national guidelines, which I authored, and in the new guidelines, which are being reviewed now, which I authored, and that is this. Anaphylaxis is diagnosed when a known allergen is experienced, is eaten or exposed, the patient is exposed to, at the first manifestation, regardless of what. But I would give it to any person who has eaten an allergen to which they know they have had a reaction immediately. I would head on to the emergency department and keep the second injection available, and I would favor that plan. And in our definition of anaphylaxis, this is discussed. If it's an unknown allergen, that is, you have a patient who is beginning to experience symptoms, let's say maybe hives. We usually suggest you can observe if the patient is not known to be allergic for 2 systems to manifest itself, just like the allergy the doctor has instructed here. So maybe hives and shortness of breath, or hives and abdominal symptoms, etc. And that is instructions to physicians, okay? To physicians. And I agree with that. When dealing with a patient, however, who is a known allergic patient, one doesn't wait. And an error of commission is far less severe than an error of omission in these situations. I hope I made myself clear on that. And do we have any further questions?
Well, that was the last one with the slide, but can you address, and you might have already done this, but I think it bears another repeat, is epinephrine itself a dangerous drug? And because people are afraid to give it, and I think it would be worth talking about that a little bit.
Certainly, epinephrine can cause side effects, jitteriness, a raise in blood pressure, etc. These are in almost 99% of cases, 99%, when given by intramuscular injection, as we instruct patients to do in their leg, when given by that route, these are uncomfortable but not serious. Having treated numerous episodes in my lifetime, I have never personally experienced any serious effect from this drug. We experience anaphylaxis in our office because of our use of allergy injections. I always tell a patient, you're going to get jittery with this and your heart will beat a little bit fast, and that's really all that ever happens in our experience. So again, fear is not a reason to use this drug. Fear of side effects is not an adequate reason not to give epinephrine in anaphylaxis.
Great. Is it true that up to 20% of reactions may not have any skin symptoms?
When you look at the data, you get varying results. I think it depends on where that survey was done. Was it done actually at the time of an event, or was it done afterwards? If it's done actually at the time of the event, roughly 90% will have skin manifestations. When it's done retrospectively, a much lower percent, 60 to 80%. But that's depending on recall. So I would trust the higher amount, in my opinion. But certainly, this is very important. The absence of skin manifestation does not rule out an anaphylactic event. You can certainly have an event without skin manifestations. So if you don't have skin manifestations, it does not get you off the hook. You still must give epinephrine.
Well, thank you very much, Dr. Lieberman. This has been really insightful and just very helpful to so many of us, and we really do appreciate it. We did have some folks asking things like, what are the symptoms of anaphylaxis, and we have a really nice handout on our website regarding that, and so we will be sending that to you in an email following this presentation with the link to the video recording of it. So some of you had come in late, and so if you did miss it, I encourage you to wait for the email that you'll get, and then you'll be able to watch it in its entirety. So with that, I'm going to thank Dr. Lieberman for being here with us tonight. I really do appreciate it. And Mrs. Lieberman, too, thank you for joining us. And now I'm going to move on to our giveaways. We have some giveaways, and let me see. The two giveaways for Sun Butter are Ashley Kelleher and Carol Burks. And the two giveaways for Hope Page Designs are Jamie Temple and Michelle Lytle, L-Y-T-L-E. Congratulations to all four of you. We will be in touch to get these gifts off to you in the mail. So with that, I'm going to say an archive of this webinar is going to be available within the next week or so. We will send you it in an email as a link to the recording, and we'll also give you information on the next webinar. So the next webinar is going to be with cookbook author Colette Martin. She's really a talented, creative baker without most of the top 8 allergens and gluten. And so if you would like to be creative in the kitchen and you don't know how to make things, Colette really can tell you how to make them, and it's pretty amazing stuff. So please join us on June 2nd, and we'll look forward to seeing you then. And once again, this was the handout I was referring to. It's Anaphylaxis, Severe Allergic Reactions, and it will explain what steps you need to take to recognize a reaction, how to treat it, and to learn how to avoid it. We also have a lot of information about anaphylaxis and food allergy management on our website. All of our educational materials are reviewed by our multidisciplinary medical advisory team, so you can be confident that the information you're getting is clinically accurate. So I encourage you to check it all out. We have a brand new lovely website, kidswithfoodallergies.org. It's mobile friendly, so if you're using a mobile device, you can see it, and it's beautiful. So check it out and take advantage of everything we offer is free. We also have an online support community at kidswithfoodallergies.org. Just go to the community area, and you'll be able to get connected with other parents like yourself and volunteers who are trained to answer your questions. And you can search through our archives and get a lot of information on prior conversations that have gone on. And like I said, it's free and available 24/7 for you to take advantage of. So thank you all for joining us here tonight. Remember that Kids with Food Allergies is a division of the Asthma and Allergy Foundation of America, the nation's oldest and largest asthma and allergy charity. And so if you enjoyed this presentation, come back and enjoy another one next time. Check out our website and keep us in your charitable giving plans. Thank you again for joining us tonight. Have a good night.